here, and we first of all want to thank our hosts, the Health Connections Office, because they've been a tremendous excuse me, support over the past several months as we've moved our meetings to this space from the auditorium. And hopefully it works out well for everybody involved. It's been a great support for us. Before I introduce today's guest speaker, who is, excuse me. I did want to mention a couple of housekeeping notes. We like to maintain relationships with the several other groups of support, cancer support groups in the Sarasota area, one of which is our brethren at Us Too. And Us Too meets on Thursday nights, the third Thursday of each month at 6 p.m. at Doctor's Hospital. Just a reminder, I try to make sure that we get that out in our email notices every month, and we try to get those out in ample time so you can plan accordingly. The next group is the Charlotte support group that meets on the Friday, usually following the Thursday night meeting of Us Too. So it seems like all three of us are kind of grouped together around the same period in each month. And then there is a fourth group that's a much smaller group that meets at the Jewish Family and Children's Services Center, if I've got that correctly. I always change the letters in the wrong direction, but they're located on Fruitville Road here in Sarasota, and they've taken over a group that had met for many, many months, years, at the Lakewood Ranch facility. A small group where only men are involved, 4, 5, 6 men, but anybody is welcome to join that group at any time. So for any information on any of that, feel free to contact me or Ed Weinsberg. Our numbers are on virtually all the literature, so please give a call. The next item is that a presentation is going to be made next Monday at 11 a.m. about our group, about Men to Men, and about cancer-related experiences from Mr. Paul Zatz, who I am about to introduce our speaker. Paul is the former chair of Man to Man and went through the period when we transitioned from Man to Man to Men to Men. Long story I won't bore you with, but nonetheless it's worked out very well. And without further ado, I'd just like to have Paul come up and introduce Dr. Sam Smith. Paul has been chair for a lot longer than I've been co-chair and has known Sam for many, many years, and his experience, I know, is going to be very enlightening for all of us. So, Paul?
Thank you, David. And thank you for doing this now so I don't have to do it anymore. Share this anyway. It's my pleasure to introduce our speaker today, Dr. Sam Smith, who's been on the board of directors of Man to Man and Men to Men for many years and has been a friend and speaker. He has an impressive curriculum vitae, which if I started going through it now, we would be here for a long, long time. But he's a graduate of Dartmouth College, University of Rochester School of Medicine, internships in Denver. He was obviously in the Army and a battle group and battle surgeon with the 82nd Airborne Division. He is a diplomat of the American Board of OBGYN, has practiced medicine for many years, retired now, if I am correct, and has been a speaker to our group a number of times in the area of sexuality. So without going through all, and I'm sure this vita is not really up to date, so there's only about 20 or 30 different organizations on here, so I'm sure there's a lot more now that he's been active with and participates in. So without further ado, a friend of Man to Man and Men to Men, Dr. Sam Smith.
Thank you, Paul. I don't need this. I'm mic'd up. You can hear me, can't you, with this?
I can talk over you.
Good, okay. Thank you, Paul, for that introduction. Um, just forge right ahead. I cannot see, I cannot pee, I cannot chew, I cannot screw. Oh my God, what can I do? My memory shrinks, my hearing stinks. My sense of smell, I look like hell. My mood is bad, can you tell? My body's drooping, I have trouble pooping. The golden years have come at last. The golden years can kiss my ass. Now, I like to start out with this, with apologies to Dr. Seuss. Because can you recognize that all of those things we have all experienced, or most of us have experienced, and all have an impact on our sexuality. So, nice kind of a whole thing. Why do I have some credibility in this subject? Number one, I was an obstetrician gynecologist, and I had a particular interest in female sexuality. You don't get any training in that, in the regular training, so you had to go to do extra. And it was at the time, really, that when I went into private practice, that Masters and Johnson came out with their interesting data. And I had to fight my way through, too, because that was couple therapy, and I didn't have a couple to do that with, so we had to look at other areas. But then as far as male sexuality is concerned, I had a radical prostatectomy in '98, and by choice, I said, don't bother sparing the nerves, because I felt that if you spared nerves, you might spare cancer, because the nerves sit right on the prostate. So I had to learn a whole lot about male sexuality, because obviously with no nerves, there's no spontaneous erections, and the drugs don't work either, the pills. So, what am I going to talk about? First of all, our developing sexuality, what we learned, because we cannot look at what happens to us with prostate cancer therapy, no matter what it is, without kind of looking at how we are from a lot of different other angles. What do we grow up with? What do we learn? That kind of thing. And how has that impacted our life now? Maybe some of the things we should have learned I'll touch on. The normal aging changes in men and women, drugs and medical conditions that affect us, because that we have to take into consideration too when we're talking about what prostate cancer therapy specifically affects us. And the specific effects of prostate cancer therapy, a little bit about penile rehabilitation, and what I think about that, and what to do for what you may want to do, and a brief word on safe sex. So, how we brought up sex sexually. Well, no, none of us were in the 40s. None of us, I don't think, were old enough to be in, maybe some, in World War II. But that still affected all of us, because maybe our dad was off in the war or something. That was the time of, and of course with the troops, the number of condoms passed out was enormous. But curiously, they would never allow any of the waves or wax to get any, which is, I think, an interesting comment on our whatever. Well, penicillin was invented in the 40s, and that really helped in terms of all the sexually transmitted diseases. The Kinsey report came out in the 40s, the first time that somebody had looked at what the sexual practices of American people were. In the 50s, the dress was look but don't touch. If you can remember, we were all looking for a home run. You know what I mean? Maybe first base was something. Keep that in mind in terms of what I'll talk about later, but just keep that back of your mind. Playboy, the first issue of Playboy was published in the 50s. It was not labeled the #1 issue because Hefner didn't know whether there'd be a second issue. And of course, there has been multiple issues. I don't know if you're also aware that this past month was the first really huge change in the magazine. There are no nudes anymore in the magazine. Publishers, I guess, felt that you didn't. It's so ubiquitous over the internet or anywhere else that you didn't need to put them in a magazine. I don't know. Okay, in the 60s, oral contraceptives were invented. It was the Masters and Johnson published their book, Human Sexual Response, the first people to look at the physiologic changes in sexual interaction. It was the time of the movie ratings, the X and so forth. In the 70s, marital aids, vibrators, were now sold in department stores rather than sex shops or something. X-rated movies went to regular theaters rather than sex shops. And Roe v. Wade, the court legalization of abortion was in the 70s. In the 80s, it was felt that the sexual revolution was over. There was herpes, and then AIDS became popular, or not popular, but popularly noted. Advertising started, and it has persisted to this day in sexual terms. We really rarely see a car ad without a bikini-clad gal or something, so that advertising consisted. In the 90s, the internet led to cybersex. Viagra was invented. That was serendipitous because it was really tested as a heart drug, and it didn't pan out. It didn't do any good, so the drug company that was doing this tried to get the Viagra back, and the guys wouldn't they said, we'll hang on to it. So it was serendipitously discovered that it helped erections. And then there was Clinton and Monica. Well, here we go in the 21st century, and really America is still in the dark about sex. We are fixated by pedophile priests, fashion ads, their soft porn, primetime pulses with the sexploits of its young characters. The internet burns with broadband erotica. Pop lyrics are explicit, and Viagra's numbers are going up. More than 10 million men across the country are taking it. America, like some randy teenager, is oozing sex. Unfortunately, like that same teenager, it is extremely ignorant about sex. Though we seem to be in a national state of arousal, experts say that we have long neglected the basic research that could help us better understand human sexual behavior, deal effectively with child molestation, and battle the spread of sexually transmitted disease. Sex has shaped all aspects of our life, fashion, art, language, politics, religion. Still, even today, we have this huge hypocrisy. Easier access to morning after pills would only promote irresponsible sexual activity. Here he's with all this Viagra, girly magazines, etc. I think even now we have an interesting thing. What crossed your mind when you saw the ad, the Viagra ad, and they said, oh, now packaged in individual pills? That's for. Okay, this may be our first brush with sexuality. It really is one, he says, let me hear it meow. I think he has a little curious about what he thinks his name is. And with this, I'm going to control your life. I think we can relate to that, gentlemen, can't we? Or we may be like this, and then it says insert tab A into slot B. And just to see how modernized or continuing here, here he says, our settings are different. She says, yes, you have a Wi-Fi antenna, and I have a USB port. So it's right, we're thinking right up to the current times. We brought up with a bunch of myths. Now, we never know who told us them, some older guy or somebody who really knew. And so we get brought up with sexual responses, natural and automatic. Well, particularly now, can we say that? Not at all, because aids are necessary. our partner is responsible for our sexual response. Not really. Our partner provides an environment, but we are responsible for our own sexual response. Sex, as elsewhere, it's performance that counts. That can get us into trouble. Well, it's spectatoring when we're sort of hovering over ourselves and saying, I wonder how I'm doing. I wonder, boy, that can lead to problems. Man must always take charge of and orchestrate sex. Well, is that really true? A man always wants and is ready for sex. And that's, again, a myth that can get us all into trouble. Males and females are completely different anatomically. Not so. I will show you that we're more alike than we are different. Having sex equals having intercourse. That is really not true. And I think that we get into all sorts of problems and we lose out on so much. Because if you can't have intercourse, you can't have sex anymore. I mean, this is a total myth. Intercourse is always the goal of sexual activity, and as it is the best for both him and her. Now, how did we get to that? I think we got to that because little guys and little girls were brought up differently. We were told to pee, and we were told to pee, frankly, by our parents, too. And when we had to pee, you hung on to it so you wouldn't spray all over the bathroom. And then when you were finished, we were told to shake it. And if we shook it enough, something extraordinary happened. I think we learned our sexual response. Now, what was she told? Don't touch. That's dirty down there. Save it for marriage. Which is kind of crazy. So she grew up not knowing anything about her sexual response. Okay, now they're both in their late teens or whenever they get together, and she's being taught by him. And of course, he's found out that it feels a heck of a lot better, penis in a vagina than in his hand. And so he persuades her that this is the very best thing in the world. I will point out that that is, again, a myth. Erection is necessary for sexual activity. No, no. An erection is necessary for orgasm. No, no. An erection is necessary for intercourse. There's no question about that. But for sexual activity generally or orgasm, no. Good sex is described as a linear progression of increasing excitement, terminated only by the male orgasm. Remember her, don't we? Fantasy is sinful. Well, if you heard remember George Carlin fantasizing about Wanda? He figured out there were 7 sins, thinking about Wanda's breasts, thinking about touching Wanda's, and on and on and on and on. And they were all sins. But that really is not sin. Intercourse is primarily a procreational activity. In the rest of the animal worlds, yes. The female accepts the male only when she is in heat. Then can become pregnant. In the humans, the female, two things. Number one, we never really know when that ovulation occurs. There's no physical sign that demonstrates specifically. And she accepts the male anytime during her cycle. So intercourse is a relational, recreational activity, and it's accidentally procreational, not primarily. Men should last forever before orgasm. I don't think our partners always think that is the best thing in the world. So that's another myth. Men are sure that a large penis is most desirable for their partner. Now, here he is looking in a mirror, and I know how small it is. A gentleman recognized that he's looking straight at it. When you look straight at something, it looks a lot smaller than from the side. So he's already behind the 8 ball looking straight at it. Fairy godmother appears. What are you whining about, she says. Oh, my willy is so small, he says. like them. How about one that reaches the floor? You know, in for a penny, in for a pound. Cock crow in the morning, your wish will be granted. He goes to bed with a big smile on his face. Big smile in the morning when he wakes up, jumps out of bed, and his wish has come true, and you have to be careful about what you wish for. In this enlightened age, the preceding myths no longer have any influence over us. Right, right. So, kind of summarize in terms of thinking about all the myths that say intercourse, 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 intercourse. Intercourse is the goal of sexual activity. Erection is necessary for sexual activity and/or orgasm. We should last forever before orgasm. A large penis is most desirable. Good sex ends with a male orgasm. But only 30% of women reliably orgasm with intercourse alone. So, what are we doing? Or what are we thinking? Well, so what are some of the things we should have learned? We all start out like this. Block anybody's view, but I can see if I can point. I don't know why red dots don't work on these things. Anyway, we all start out with an undifferentiated gonad. You go either way, and to these two sets of tubes. And depending upon our genetic makeup, and this is generally because there's huge variations, but those are very rare. If we're XY, that red tube system predominates, and it forms the epididymis, the vas deferens, the seminal vesicles. And the blue tube kind of disintegrates. Well, first of all, that undifferentiated gonad becomes a testicle and starts to produce testosterone. That creates this thing. If, on the other hand, we're XX, female, then that undifferentiated gonad becomes an ovary, producing eggs, and that blue tube predominates. And it forms the fallopian tubes, the uterus, the cervix, the upper third of the vagina. Parts of that red tube do remain in most women. And sometimes it become clinically important because they can form cysts, and then it can be confused between are they cysts from ovaries or cysts from this stuff that's sort of around the side. There's a primordium that is the Cowper's gland, which is the gland that produces the pre-ejaculatory secretions when we're sexually aroused. I don't know what it does in the Bartholin gland. This is an organ that I really don't know what its function is. I don't think anybody knows what its function is. And its function is not to lubricate the vagina for intercourse. That is a separate thing from the sweating from the vaginal walls. But in addition, the Skene's duct and is the same as the prostate in the male. That can vary in huge amounts of size, the Skene's ducts in the female. It cannot enlarge so much that when somebody says, well, she ejaculates with the orgasm, that's urine. There just isn't enough fluid to see a huge gush. Now, what happens, well, this is another looking at it, starting from that and then female or male. Externally, the same thing happens. We all start out undifferentiated at the top. And follow the color coding, because with a color coding, the same nerves and blood vessels go to either the male genitalia or the female genitalia, the same thing. So that that red area there becomes the median raph of that line that goes down the back of our penis down to the anus. Oh, the female, it forms the vaginal, vagina minora, labia minora, the small lips. And the big blue thing forms our scrotum, but it forms the labia majora in the female, the outer lips. And most important, the same nerves that go to our penis and our head of the penis and the shaft of the penis go to the clitoris in the female. So that's when I say that women, only 30% orgasm with intercourse alone. That's with no clitoral stimulation. With clitoral stimulation, orgasm. That's another way to look at it. At this stage, you could not tell whether the fetus was going to be a male or a female because everything looks just as pretty much the same. Fully developed. The nervous system effect on sexuality is huge. It affects every part of our body. Things got to start in the hypothalamus. There's a group of neurons in the front part of the hypothalamus that were found to be larger in heterosexual men than in women or homosexual men. Now, I've had some neurology friends, and they've done some dissections and some identification of nerve, brain. And he sent me this slide showing the dog, the food and running area, the licking area, the chasing car area. I said, well, what about humans? This is what we deal with. So here the female and intellectual interest, shopping area, romance, relative sex area, commitment zone big, art concerns, family concerns. That does contrast with the male. Intellectual interest a little bit in the front part of the brain and commitment zone. Look how big that is. Sports and finance kind of predominate. So all parts of our body, all the end organs, muscles, vessels, heart, and arousal and orgasm are affected neurologically in both the male and the female. This can occur from from our brain, how we think, how we see, all of the senses, sending nerve impulses down to change things in the genitalia. But there's also a local response sent from the spinal cord out to the genitalia. Now, generally, or things can work by themselves, just by thinking. Now, this happened a heck of a lot more when we were younger, when we thought about sex or saw a naked girl or whatever, that created a response. And that probably in most of us does not been affected as but there can be just local. That's why somebody with a cord transection can have an erection. Because there can be just local stimulation that can have a feedback and have a response. But generally the two work together. But we also have to recognize the fact that from the brain there can be inhibitory responses that can then kind of squash a sexual response. That's particularly when we think about performance. As I talked before about, that performance counts. Well, if we think about only performance, then we get into the situation where we have a fear of failure, an anxiety that produces interferes with some phase of our sexual response, and then a sexual dysfunction. But if we look at all the things that can occur in the brain, the visual, auditory, tactile, olfactory, gustatory, taste, memory, imagination, and keep memory in your mind too, because that's important. But there can also be the local. with the tactile stimulation of the genitals, or even some either bowel or bladder stimulation, that we can have a feedback with can we get what we call a sacral erection. So the female sexual response is an interdependence of central and peripheral. In other words, that works together, how her head is, where she's at, and the whole thing, and peripherally how she feels. But the central, her head, predominates. And desire is responsive rather than primary. Now, I'm sure everybody, well, I don't know how much you've been following the news of this new pill that's been supposedly available for desire, but that's thinking desire comes first, and it really doesn't. Because if we look at models in the past, Masters and Johnson started out with arousal as the first thing, and then plateau, orgasm, and resolution. Kaplan said, wait a minute, desire comes first. But then Bassan said, well, wait a minute, a lot of women, particularly as they get older and longer-term relationship, they don't have desire initially. What happens is that if they are in an emotional intimacy situation and are comfortable with being stimulated, then arousal may be starting, and then desire. So that it is not primary. Desire is not primary. So trying to create a pill to make it primary is really not what happens with women. Another way to look at this thing, emotional intimacy, motivates a sexually neutral woman to be allow a sexual stimulation, can lead to arousal, desire, and so forth. Now, last fall, this was in the Playboy Advisor. I'm a 40-year-old woman in a loving and successful marriage with a wonderful man. We count ourselves lucky because we're both fit, attractive, and reasonably happy with our jobs and home life. Our sex life is decent, but my husband complains that I never initiate intimacy, which is true. I don't have a burning desire for sex. But once I'm aroused, I'm ready to go. The way I see it, the ball is really in my husband's court. Then she, her main problem was how he invites her to be sexually intimate, and it's sort of crude. Are you time to ride the boner machine, and so that's really but there isn't a perfect example of what I'm talking about. How women do not have initial desire, that they are receptive if they're comfortable. And Deborah Huntley talked to this group many years ago. What she said, and I won't read the whole thing because this is a portion of it. For women, once they have children or become accustomed to their partner, the sexual response cycle is hardly ever where they start at arousal. They have to start up higher, and at the very top is the word willingness, and then perhaps arousal, and then perhaps desire. For men, the response cycle during most of their life starts at arousal, but with women, it doesn't. When the man makes overtures towards his mate, she might well be thinking about anything else, like doing the dinner dishes or returning a telephone call. She's at zero arousal, but with a willingness to go along and a touch from her mate, she will begin to pick up some desire along the way. If there isn't that willingness, then often the couple becomes polarized, where one person, often the man, feels like he's begging for sex and having to jump through hoops to get it. The woman, on the other hand, can't understand why he wants it so much. So this is, it must have been 20 years ago, I think I got this, out of the old newsletters that Man to Man used to publish when I was still living in Connecticut. Okay, arousal correlates well with how mentally exciting a stimulation is. Again, the central issue. That's why this thing was a complete dud. It's a clitoral pump, and this was FDA okay this for marketing. It cost about $400 or $500, and it was never tested against a vibrator. So, this was silly. And then this was from an English newspaper back in the early 2000s, where drug firms were accused of inventing the female malady and trying to make great pills to it. So there has to be a willingness and emotional intimacy first. But we really have to add satisfaction to the response cycle, and so that there isn't always necessarily the thought of orgasm. And again, men, as we age, sometimes orgasm is not available. We can't last that long sometimes. Achieve orgasm. So we have to think again. We have to think in terms of satisfaction. Okay, the male sexual response, a hypoactive or a decreased desire phase is really unusual. We generally have positive desire thoughts but age or a long-term relationship, we might have trouble with arousal. Simplify things. The top thing is the male button turn on, and the lower are the female turn on. A little different. Another thing that may be kind of a difference between males and females is look at that. She's looking in the mirror, and what does she see? Perfect body, but that rump and the whole bit. And there is a difference between looks in the mirror and how we look in the mirror. Well, life changes can affect our sexuality. Long-term relationships, children. Zits is one of my favorite cartoon things. Jeremy was just playing Starway to Heaven on his guitar. She says, yeah, one of our favorites. I told him that we were listening to that song the night he was conceived. Oh, you did? How did he handle that? I suppose it made him a little uncomfortable, and there he is trying to drown out the sound. So work and social and other interests affect us. What are the normal sexual changes of aging? And we have to crank in that with all, again, looking at responses to prostate therapy. The changes in women, a decreased skin flush. Now, recognize that if this wasn't available or happening beforehand, that's okay. But, some women flush when they're sexually excited. That decreases when they become pausal. Muscle tension, distension of the urinary meatus, which is the outside of the urethra, that distends, a decreased swelling and decreased reaction of the clitoris, a decreased swelling of the vaginal lips, diminished breast size increase, slowing or absence of the Bartholin gland secretions, decrease in vaginal expansion of the length and the width, decrease in the orgasmic platform, which is the blood filling the pelvis. That's what we call the orgasmic platform. Fewer and more painful uterine contractions. This is the most important, delayed or absent vaginal lubrication. You look at, this is a picture of a premenopausal, healthy vagina. And see all the ridges? Just recognize that thing can expand hugely. Menopause, all those disappear, and the thing is a smooth. It can't expand as well. It cannot lubricate. Changes in men that occur, decreased response to visual stimulation. Doesn't race our motors like it used to. Watching a Super Bowl, prancing across the television screen, naked. What do? Invite her to move away from the screen. Longer time to erection less firm and full. Erection loss may not regain it. Plateau phase longer and less ejaculatory demand. Smaller and less forceful ejaculate. And the orgasm can be less intense. Can be a ho-hum. Oh, I guess I did. Refractory period longer. That's the period between erection, sexual encounter, orgasm, what have you, and the next one. For teen years, it might have been 5 minutes. Now it might be 5 weeks or 5 months. For rapid loss of erection after orgasm. So there has to be a willingness for both, really, what it amounts to. For older men, particularly with prostate cancer, and women are closer in the sexual response cycle, as willingness is necessary for both. Because it ain't the same, like it used to be. You rolled over, had an erection, and had intercourse practically. It doesn't happen. You have to be willing to either think in terms of doing something for erection, for intercourse, or saying, wait a minute, that's not a necessary thing to maintain intimacy, to maintain contact. What are some of the drugs and medical conditions that affect our sexuality? Sedatives, analgesics, steroids, all can have a negative effect on our sexuality. Drugs for peptic ulcer, glaucoma, antihypertensive drugs can have a profound effect on erections. Alcohol abuse, drugs, weight reduction, even antihistamines can have a negative effect. And antidepressants can certainly have a considerable. Here's a kind of a laundry list of diseases that can have a negative effect. Okay, what are some of the specific effects of prostate cancer therapy? The loss of nerves and loss of blood vessels really is the bottom line on all these things. Surgery, it's early, it's right away. And radiation, it's late. Surgery, the penis becomes shorter. I don't think everybody who I've talked to has had a prostatectomy. I said, did your urologist tell you your penis was going to be shorter before? No. I don't know of anybody who's told that ahead of time. It makes sense, you're taking out how much of the urethra, prostatectomy, find it back, his penis is going to be short. Number one, but number two is the effect of the lack of oxygenation and things that change with disuse atrophy, if you will. I don't think we really know exactly what the erectile process is. What is the ratio between blood in it and keeping blood in? I have this little bit of there was a study, and I'll show you a little bit about that. And with the surgery, there's no ejaculate with orgasm. No, nothing from the seminal vesicles, vein fluid, and certainly no sperm, because all that has been cut off. We kind of make a generalization that if both nerves are spared, there may be about 50% potency. One nerve spared, 25%. Now, really good studies are few and far between on how men are functioning following therapy. So this study was done by Martin Sanda in Michigan. And what he did was to look at conformal radiation, which is, and we can make kind of a preliminary statement that I don't think there's a whole lot of conformal radiation being used now. There are other forms of radiation that are trying not to be the kind of the total zapping with different things, cyberknife that makes some difference. But none of these things have been around long enough to say, is there really a difference? Or can we go back to this data with the whole thing? So it was conformal radiation, brachytherapy, which is seeds, and prostatectomy. And all the procedures were done by people well experienced, and a questionnaire with follow-up in 2 years, and then again at anywhere from 4 to 8 years, and 6 years was kind of the. And what they did is to look at urinary incontinence, urinary irritive symptoms, having to go all the time, feeling the thing burning, bowel symptoms, and sexual symptoms. And they scored them from 0 to 100. If everything was perfect, it was 100. If everything was absolutely nothing, it was 0. So things were scored in that general thing. And here we can look at, and also controls. So people, men of similar age, they may or may not have had prostate cancer, but they did not have any therapy. So if we kind of look at this generally, sexually, 63.3 on the controls. So we're not comparing the effects of prostate cancer therapy against 100, let's say, sexually, it's 63.3. But with a radical prostatectomy, this is the second thing, 4 to 8 years. 38.5, conformal radiation 35.1, and brachytherapy 27.9. And kind of to emphasize this control and where we are, this is kind of a nice visualization of how penises are from age 13 to 31 down to 65 and onwards, and I think this kind of demonstrates very nicely. So we're looking at that as the background of this therapy. Okay. So we can again look at these things in that context. Kind of the generalizations from this thing after radiation therapy and brachytherapy, there were the urinary irritative symptoms improved, incontinence worsened, the sexual function declined, but interesting, with limited associated impairment or bother. Now, I don't know if this was the basis of the fact that there was older men that had the radiation therapy rather than the prostatectomy. I don't know, but it was kind of interesting situation. And after prostatectomy, stable after 2 years. So I think we can look at this as the key factors that kind of dictate sex after prostate cancer therapy. First of all, it was a baseline function. How well were we functioning before therapy? Secondly, the surgical technique. Was there nerve sparing or not, either unilaterally or bilaterally? And they also looked at retaining the tip of the seminal vesicle. And that has a profound influence. Now, whether leaving the seminal vesicle in is malpractice, I don't know. But it certainly has a different effect on how well somebody functions afterwards. The size of the prostate is important. And also, the importance of sex. If a guy isn't particularly, it's not important to him, then it really colors how he kind of views his outcome. This is the prostate here, and that's the seminal vesicle, that green thing. See how much nerve there is on that. So, and see how those nerves are just plastered on these organs, and that's why saving them, they have to be touched, they have to be moved, they have to be. So they're going to be traumatized, and how well they bounce back or what have you makes a difference into how well they work. So looking at the seminal vesicle sparing with then nerves plus nerve sparing, 57% did not need a medication or device to add erection. But only with bilateral nerve sparing, only 25% after 1 year after post-prostatectomy. See that in charting. That upper line is the score with seminal vesicle. bilateral, unilateral, or none. The blue line is no nerve sparing. Looking at the importance of how things were before therapy, these outcomes are related to men who had a high function before the therapy, with nerve sparing and at 24 months, 75%. Seminal vesicle sparing and nerve sparing, and 64% with bilateral nerve sparing. He kind of thought about redoing the study, and he added one thing particularly in this study. He added the spouses, not knowing if he was getting accurate data. He had the spouses. It's sort of the same thing as asking men how often their mate orgasms. Always, or asking her, there may be a difference. Well, anyway, in this study, they had 1,200 patients and 625 spouses, and pre and post evaluation. And excuse me. If you add hormone therapy with brachytherapy and radiation therapy, you had a worse quality of life. Brachytherapy led to long-lasting urinary irritation, bowel, and sexual symptoms. And treatment-related symptoms were worse with obesity, a large prostate, a high PSA, an older age, and a black race. Another study was looking at men in their 50s, less than 55, 55 to 64, and greater than 65. Pre- and one-year evaluations. And in all age groups, 50% decrease in sexual function, but greater bother in the less than 55 and greater bother if AIDS needed. And that's a reasonable outcome. The younger guys, that they had to use something to create an erection, that they didn't like that as much as the older guys who might have said, okay. Curiously, if in a relationship, decreased bother with urinary symptoms, and I don't know why that was a thing. Anyway, impotence is a combination of neurogenic. It's a loss of those cavernous nerves that modulate smooth muscle tone. Arteriogenic, loss of accessory pudendal arteries, is the blood flow coming in. And venogenic, corpocavernosal dysfunction. And it's progressive smooth muscle dysfunction. That's from the lack of oxygen or disused atrophy. Now, this is a study about looking at what is more important, in or out, or keeping in. And this was done in China, which was the only place that can do something like this, I guess. They had, and I don't know if they're volunteers or not, they had 15 cadavers that were rapidly frozen after death, preserving tissue. And then they were, particularly their penis, unfrozen, controlled thing. So they really eliminated the influence of hormones, artery, blood flow, neurologic, sinusoidal, pharmacological, and psychological factors. So they really had a captured, really good thing to look at. And what they did is to catheterize veins and then pass fluid in. And the preoperatively at 28.1 milliliters per minute for a rigid erection and with an intracavernosal pressure of greater than 90 millimeters of mercury. Then they tied off the veins, and they only had to have 3.1 milliliters, or 7.3 with a fourth, with 3.1 to 13.5 to achieve the same result. So it really showed that if there is good venous blockage then it doesn't take, a whole lot of input to get a firm erection. And most everything working on trying to achieve erections is looking at the arterial flow and the venous flow. Okay, this is look at all the veins and this is all the veins in the penis. Okay, penile rehabilitation. The rationale for it was that Mulhall recognized that there was a significant and continuous venous leakage after prostatectomy, and the smooth muscle cell death, and irreversible veno-occlusive disease. And he felt that if you continued to stimulate the penis immediately, then it might prevent this becoming a problem. So, various methods to achieve the rehabilitation, the vacuum devices. This to me didn't make a whole lot of sense because when you use a vacuum, you're pulling venous blood into the penis. So it really isn't oxygenating using the prostaglandin either by injection or the suppositories, and is another method of trying to rehabilitate, and then using Viagra, and which is, I think, is I've heard that everybody who I've heard who's had a prostatectomy is told by the urologist to get their Viagra, and they get it from Canada or Cambodia or someplace, I don't know, because otherwise it's very expensive. Well, some of the problems with this whole concept is that, again, with the vacuum, it's venous blood. With injections, is a compliance. How often do you want to inject your penis every day? Get an erection, and you're probably not going to use it, and how thrilled you're going to be with that. How well were this controlled? And the studies with injection or pills, was there a placebo effect? And theoretically, with any of the PD-5 inhibitors, you just don't take a pill and get an erection. You have to stimulate your genitalia. Well, do you really want to take a pill and masturbate for the next 6 or 8 weeks after you've had a prostatectomy? I don't know. And so I think that the importance of sex to the individual, the importance of having an erection, the importance of that, it makes a whole difference. So we need more studies on this whole thing. Okay. Umpteen years ago, when my wife and I teach parents how to talk about sex with their kids, we kind of developed this concept of having sex. And again, let's go back to trying to get a home run at first base. If you got to first base, did you think you were having sex? You betcha. Having sex, unfortunately, it's labeled having intercourse, but it's much more than that. But we developed this idea that those lines are verticals, that everybody is responsible to dropping those verticals, and particularly with the adolescent, rather than carrying on, from one to the next. One of my classmates, when I first presented this at our reunion, told me later, he said, Sam, hand-holding is not having sex. So the next year, sitting there with his wife, I went up to his wife and I took her hand and I, holding it but caressing it, I said, Scotty, are we having sex now? Yes. So she got it. She understood. So, but one of the things that's for the aged, signals can change. one of the things that guys might do is, what do they do to initiate a sexual encounter? And it may be that he, kissed her neck or caressed her breast or something like that. And maybe later on in their relationship, all he wanted to do was to caress her breast. Well, that was a signal that she said, oh, damn it, he wants to do it again, kind of thing. So it rejected him, and so that intimacy could be lost. So that there needs to be communication, but you also have to know where they are. Okay, if intercourse is planned, you need help with the erection and lubrication. That is not going to be very helpful, but you use a condom if you're over 50. But there's pills that they work. The vacuum pump, which is a cylinder placed over the penis and negative pressure. There has to be a ring put at the base of the penis to hold the blood in. Urethral suppository muse is pure prostaglandin. Pure prostaglandin creates a big pelvic ache. So that can be a problem. The injections, Caverject again was a pure prostaglandin ache. And Trimix is a mixture of these three drugs and can be in different amounts and different proportions. The most final thing is a penile implant, which if it doesn't work or whatever happens, and that's it. You're not going to, nothing else can be used after that, if it's infected and removed or something. But I think that's the closest thing to immediate erection, because the cylinders in the penis, a reservoir suprapubically by the bladder, and the pump is in the scrotum, and you can transfer the liquid from the reservoir into the penis. I don't know if you've ever seen this ad. I never expected pain, she says. I think we failed as doctors if a woman goes into menopause and she haven't told her that she's going to have pain. Doesn't use something to lubricate. And that something can be either a water-soluble thing like Astroglide or KY warming liquid, vaginally or patch, or SERMs are things that are like estrogen but do not have necessarily the negative. This is more mainly, I thought that was valuable up at the villages when I did this, because one of the reasons for the increase in sexually transmitted diseases is that the retirement communities are like college campuses, number one. Everybody's the same age, are healthy in the whole thing, and they didn't get the safe sex message. Condoms we grew up with were for preventing pregnancy. Well, if our partner's older, we don't need that. But we do need it and it's interesting that one of the things they're finding out that kids that use birth control pills frequently use condoms. And kids that have now IUDs or the long-acting contraception don't use condoms. An increase in the problems in sexually transmitted disease, long-term contraception. Also, the docs don't ask elders about sex life. So, getting tested, choose a partner you can talk with, using condom, lubrication, spit, don't swallow, and Google safe sex. Okay, what to do? Again, let's think in terms of having sex is a continuum, and that you lose if you just think it in terms of intercourse. There has to be a willingness for both. Join them. They're having sex. They're kissing, they're hugging, and they're probably remembering. Thank you.
Much, Sam. Great presentation, lots of information. Any questions that anybody has as we break up as close to 3 as? Go ahead. No, it's been shown that
that there is no difference generally, in the size. Of course, we always think in terms of everybody bigger, particularly if we're at an old-time football game where the urinal was a big trough. You happen to look down the side there. Geez, everybody's bigger than me.
They've modernized everything now, haven't they? Any other questions? If not, thank you all for coming. We hope to see you again in a month, and I'll make sure we get emails out to everybody. Make sure you get your emails listed correctly. If we can make sure that I'm not the best speller, so I have to watch carefully, but we've got lots of information coming out, not only about meetings, but about other events. And we'll have a video available of this and the previous event as well very, very soon. Yeah. Thank you, folks. Thank you, Sam.